is that
So sorry, that's my fault. I forgot to press the record button.
that's okay.
Oh, sorry,
Okay.
Ian.
I'll do it again for the recording. So my background is, I'm a psychiatrist. I initially worked as a physician for a number of years and then became a psychiatrist. So I've been practicing for about 22 years now. And so I spent the last 10 years in Oxford working with medical and surgical patients. So treating a lot of trauma and a lot of kind of overlap between physical and mental health problems. So ranging from kind of eating disorders to people who have had trauma after military service or after road traffic accidents and all the other things that you see in general medical hospitals. And recently I've started working as a clinical director of a psychedelic research organization. So some of you may have seen psychedelics in the news, promising new treatment for mental health problems. But it's very relevant to this presentation because psychedelics offer a really interesting opportunity, I think, for different professionals who don't normally speak to each other to speak to each other. So, psychiatrists and psychologists and sociologists and so on. And so it's come at a very opportune time. So I'm just going to share my screen. And hopefully you can see the presentation, and I'll start slideshow. So you'll let me know, you'll shout at me, Kira, if the slides don't go ahead. So
Sure,
explanatory models, and I'll explain what I mean by that in a second. So we'll talk a little bit about what an explanatory model is, and then think about how the medical model, which we're all very familiar with, has become so dominant. And it's so dominant, in fact, we may not even know that we're in a medical model. And we'll think about what are the other ways of thinking about distress, disorder, illness, ill health, whatever you want to call it. And then how can we kind of bring them all together, because they all have something to offer. So first of all, as I said, I grew up in the medical model. I was trained as a doctor. And when you go to medical school, you're trained in a particular way of thinking that we'll come to in a second. And I think this influences how we view, anyone presenting to a doctor. And I think it influences the way you think as well, the type of thinking that you become good at, which may not be well suited to, for instance, thinking about complex issues like mental ill health, emotional ill health, relationships, and so on. And as Chiara mentioned, complexity science is a big interest of mine. And we'll actually talk a little bit about that at the end of the presentation. So first of all, what is an explanatory model? So an explanatory model is a sort of a model that you build in your head of how something works. So this is a picture of an orrery, which was used to illustrate how the solar system works. So people know that before Copernicus, everybody thought that the sun and the planets revolved around the Earth. And Copernicus realized that actually the planets and the Earth all revolve around the sun. And it was a huge shift in scientific thinking. But this is a model that was used to illustrate to people how that might work. So, and we all have a model in our heads about how various aspects of the world work, even if it's not explicit. And we'll talk through a little bit about how different people think about these things. Medicine has always had a model of mental illness or suffering or mental disorder. You can see on the left here, this is a painting of an exorcism. And on the right here, some of you may be familiar with the four humors. So black bile, yellow bile, blood, and phlegm. And for 2,000 years, pretty much, this concept of the four humors was the dominant theory about physical ill health and mental ill health. So right up until a couple of hundred years ago, we talked about disturbances of the four humors. So if you had too much of one, you were one way. If you had too much of the other, you were another way. And that was the way we understood why people got sick and why people got, depressed, or why people developed psychosis and so on. And it's still present in our language. We still describe people as melancholic or having melancholy, and melancholy means black bile. We'll describe people as phlegmatic or sanguine. And all that language comes from this theory that completely dominated Western thought for about 2,000 years. So psychiatry so medicine has always had like a model of, why people suffer and what's going on in the body and so on. Not terribly scientific models by today's standards, but it just goes to show that people always have a kind of an understanding, even if it's kind of folk understanding of what's going on. And everybody's got a pet theory. I couldn't resist using Midjourney to create a picture of a pet theory. Everybody's got a pet theory of their own problems, and it might be very accurate or it might be wrong. So both patients or clients or just people in general have a theory about why they're happy and why they're sad and why they're tired and why their tummy hurts, and so on. And also professionals have pet theories. They have particular, so if you're a doctor, you'll have one set of ideas. If you're a psychologist, another set, a sociologist, another set, and so on. And these are some examples of, because I say to patients, why is it that you feel this way? Because, it's important for me to understand where they're coming from, because either they might have an insight that I'm not aware of, or they might have something that I disagree with. And I say, okay, well, let's try and figure out, let's work together to kind of figure out what's going on. So a person might say they're depressed because of something that happened to them. Right? Something happened to me, and so now I'm depressed. They might say, I'm depressed because of how I think, right? I worry all the time, or I think I'm worthless. So it's the way that I think that makes me feel sad or anxious and so on. They might say I'm depressed because nobody appreciates me. Right? The people around me don't appreciate me, and I need respect and appreciation, and I'm not getting any of that. They might say I'm depressed because I'm stressed all the time. It's quite a common kind of understanding that stress is bad for you. They might say I'm depressed because I'm lonely. You don't need to be a psychologist to understand that being lonely is depressing. One patient said to me recently when I said, why do you think you feel this way? And she said, well, look around you. Wouldn't you be depressed if you lived here? It was she lived in high-rise social housing. There were very little kind of amenities close by. She was distant from her friends, and she had no social support. Wouldn't you be depressed? She made a really great point. Another person recently said, I'm depressed because there's nothing good in my life. So you can see that these are all kind of quite different explanations, but they all make perfect sense, right? They all resonate. They're all like, well, yeah, okay, that is a good explanation of why a person might feel a particular way. But what's also quite common is that people might say, I'm depressed because I have depression. And this is one of the ways that kind of medical language has, seeped into our day-to-day language. And I think you can see that it's a sort of a circular definition, right? I'm depressed because I have depression, which causes depression. I have depression. But it is because of the dominance of the medical model, it is one of the ways of thinking about depression that I come across quite often. And in order to kind of understand how this kind of medical idea has come to be so ubiquitous among both doctors and non-doctors, and other healthcare professionals as well, I think it's useful to kind of go back a little bit to about 100 years ago. About 100 years ago, the two commonest causes of madness were pellagrous insanity and what was called general paralysis of the insane. So there's a painting or a sketch of pellagrous insanity from Italy there on the left, and a painting of general paralysis of the insane on the right. So these are the commonest causes in Europe of madness. And towards the beginning of the 20th century, two very important discoveries were made. The first was that pellagrous insanity was caused by a deficiency of this molecule on the left, and that's vitamin B3. And the second was that general paralysis of the insane was caused by syphilis. So on the right here, those are little Treponema pallidum. They're little syphilis bacteria. So the two commonest causes of madness, we discovered there was a simple cause. Right? You supplement food with vitamin B3, no more pellagra. It doesn't exist anymore, pellagrous insanity. And on the right, when we discovered penicillin, we could treat syphilis, gone. You really don't see tertiary syphilis, was called neurosyphilis, anymore. And so these were huge victories for medicine. And that idea of, a disease causes a symptom, and the symptom tells you that there's a disease, and then you treat the disease. And that's how much of medicine works. And that's how doctors are trained to think. But unfortunately, this early success was a bit of a disaster for psychiatry. A little bit like these people who win the lottery and spend it all on cocaine and plastic surgery. And, they go from being millionaires to being back at their old job again in 6 months. So sometimes early success or big success can be your downfall. So after this early success, in 1980, because lots of different types of doctors were using lots of different language to describe people's suffering, they decided, well, let's all put it together in a book and let's name everything, not like as the final word, but just as a way so that we can do research. Okay, so it made sense, and a noble effort, I think, to approach a more scientific understanding of all of the things that we didn't have kind of simple causes for. So schizophrenia, depression, lots of different anxiety disorders, eating disorders, obsessive compulsive disorder. Let's name them. Let's agree on the names and let's put them in a book so that we can study them. So a very noble effort, but the best laid plans of mice and men gang after gley. And what happened is these kind of tentative categories became completely enshrined. So they became carved in stone. And then they started entering into this kind of tightly coiled kind of causal loop. So DSM-3 was in 1980. In 1987, Prozac came on the market. And Prozac appeared to be more effective than previous antidepressants, and it had fewer side effects. And it started to be marketed really aggressively, and the pharmaceutical marketing companies started to use the language of psychiatry. They would say, you have depression, you have anxiety. Similar thing happened with Valium in the 60s. And although we used different words back then for the different kind of presentations. And then this guy on the right here, in an amazing twist of history, this is Edward Bernays. And Edward Bernays was Freud's nephew. And he basically invented the modern advertising industry. So he invented the way of selling things to people by appealing to their deepest, darkest desires, which he learned from his uncle. And so what happened was advertisers started aggressively marketing Prozac direct to the public, for instance, in the US. And then once the diagnoses that were enshrined in DSM got into the treatment guidelines, that was the end of it. And so we have sort of been stuck since then with this list of disorders, which now is about 250 different mental disorders you can get diagnosed with from the DSM. It's now DSM-5. We were kind of stuck with that list. And so every funding institution in the world that funds research, and because I know because I do research trials now, you cannot do a research trial unless you have a diagnosis that it's attached to. So the whole system now is based on these diagnoses. So it's become quite a stuck system. And it's why nowadays, all of our public discourse, all of our professional discourse, and all of our treatment guidelines and all of our advertising is all about these diagnoses that were meant to be kind of tentative categories for purposes of research. So that's how we got here. So the medical model says you've got a disease, say bowel cancer, it causes these symptoms. Your doctor recognizes those symptoms. She investigates, she finds the cancer, the surgeon takes it out. And doctors, they go into medical school with I think, an ability to kind of think in a complex way about the world. But they come out of medical school very good at pattern recognizing diseases, but I think perhaps lose something in the process in terms of thinking about the complexities of the world and the way different things interact. And so it's sometimes called a latent disease model of mental disorder, which is essentially the same thing as saying the mental disorder. So the idea is that, depression causes your symptoms, or schizophrenia causes your symptoms. There's some underlying disease that we haven't quite figured out what it is yet, and it causes symptoms. So essentially, the sort of statement that the medical model says is your symptoms are caused by an underlying illness. And it takes the form of an explanatory model, but it's actually not an explanatory model. It's a sort of an assumption about how the body works. And as I said, it's now enshrined in our institutions and our medical training and so on. And throughout this presentation, what I'm going to do is I'm going to present all the other explanatory models that we have as a statement like this, to try and just give you a sense of actually what's kind of underlying them. So the medical model says your symptoms are caused by an underlying illness. And if you think about it, it's a slightly backwards way of thinking, right? Because you say, okay, how do you know you have depression? Well, because I have these symptoms. Well, what's causing those symptoms? Depression. So in one sense, it's actually the symptoms that are causing the diagnosis rather than the other way around. And over the past, 40 plus years of trying to find, this simple thing, like vitamin B3 or syphilis that causes these problems, has been a total failure. So I would say at this stage in history, that this approach has not led to improved outcomes for people, and actually, mental health is getting worse. So something is awry. Let me change my. There we go. There's a famous quote by H.L. Mencken: "For every complex problem, there is a solution that is simple, neat, and wrong." So that's something to bear in mind. So what's the next explanatory model? Well, if you're in the UK, the big boss fight is between psychologists and psychiatrists arguing with each other, medical model versus psychological models. This is a doctor fighting with a psychologist from Midjourney. There's maybe a little bit less of that in other places, but it does seem to be like a big battleground here. And psychological models essentially say that, there's something in your head, in your thinking, in your psychology, the way you think, the way you behave, that causes suffering. Is the sort of, the simplest kind of distillation of what that means. And psychological models also have a rich history, just as long as the medical model, or various medical models. So on the left here is Seneca, who's a Greek philosopher, whose ideas are actually very similar to CBT, which is one of the commonly used types of psychological treatment today. On the right is the Buddha, and increasingly in Western psychotherapies, we use lots of ideas from Western philosophy. So meditation and mindfulness and so on, and related ideas like acceptance that are used in things like acceptance and commitment therapy come from those traditions as well. And I would say that, this is a very Western idea-focused kind of talk, but I think that the principles here, including the way patients themselves, what explanatory models they have from their own cultures, and the principles remain the same. Just to say that I'm aware that it's a very kind of Western-focused talk. So a psychological or behavioral model says ways of thinking and behaving give rise to suffering. And I think that kind of makes intuitive sense to people, right? That there's a certain way that you can think about yourself and the world, or a certain way that you can behave that makes your life worse and can lead to suffering. And that's essentially the psychological model. And one of the issues with the way that we conceptualize mental ill health is that, there are loads of different schools of therapy. So this is a list of just 10 or so. So cognitive behavioral therapy and dialectical behavioral therapy and acceptance and commitment therapy and cognitive analytical therapy. And there actually are well over 200 different forms of therapy that have been developed and implemented over the years. And a couple of interesting insights from that. One is that, why should there be 200 different types of therapy? Surely there should be a science of therapy. That's actually one of the things that we're trying to introduce in our training program, to kind of go beyond a little bit all the different schools of therapy. But they all provide a slightly different way of thinking about this kind of psychological model. And we'll come on to actually broader kind of understandings, like interpersonal kind of understandings of mental disorder. So lots of different schools of psychotherapy, and each of which have their own version of that kind of psychological explanatory model. And in CBT, many of which you'll be aware of, is the most commonly used talking therapy or psychotherapy in the UK. It sort of introduced this idea of a kind of a network, kind of a relationship between things. So your thoughts give rise to feelings, which give rise to behaviors, which further influence your thoughts. So this is this idea of a loop, a little bit like the loop that happened with, the DSM and then Prozac and then advertising and so on. And these loops can get kind of tightened and self-sustaining, and that's sort of what we call illness or ill health. It's a sort of a tight self-sustaining loop. So related to a psychological explanatory model is what you might call a narrative explanatory model. So this reflects the idea that we are kind of storytelling creatures. You know, what differentiates us from the other apes is that we tell stories. So a narrative explanatory model might say something like, the story we tell ourselves about ourselves and the world influence how we feel and can cause suffering. So again, I think that feels quite intuitive for most people, I think. So you might tell a story about yourself that, you know, I'm basically a loser, you know, and everything I do will kind of fall apart, or I'm fundamentally unlovable. Also called a schema, so sort of an idea you have about yourself. Or you might tell a story about the world that you might say, well, the world is a basically unsafe place, and I'm always going to be miserable in that. And these stories have a tendency to be kind of self-fulfilling prophecies. And sometimes the critical moment in therapy is where a person kind of recognizes their story and start to kind of re-author that story, sort of think about themselves and the world in a different way. Then there are explanatory models relating to trauma. So very popular in the last few years is kind of trauma-informed therapy, for instance, and people are talking very publicly about their experience of trauma. And these models might say something like, experiences of trauma and adversity increase the risk of mental and physical health problems. So this is undoubtedly true. Adverse childhood experiences and trauma are one of the most reproducible and predictable predictors of mental health problems, but also physical health problems like heart attack and stroke in later years. So they both do something to the way that you think and the way that you develop, but they also do something to your body through the influence of stress and other factors that we'll come to in a second. So this is, for some people, this is their favorite way of viewing, you know, suffering and mental ill health. It's very much kind of trauma focused. And there's something else here, which is that this explanatory model is starting to think about like increasing the risk in a population of people. So a population of people is those people who have experienced trauma or adverse experience. So this is starting to go from the kind of individual inside the head to thinking about like groups of people and what happens to groups of people when they are abused or discriminated against or traumatized and so on. So kind of moving from an individual person model, like what's wrong with this person in front of me or what's wrong with my friend, to like, you know, what happens to a population of people who have a particular experience. So some explanatory models are very much about like me, you know, or one other person, what's going inside our heads or our bodies. And some explanatory models are more like, okay, well, what happens to society? What happens to groups of people? And then there's a movement that you might loosely call kind of humanistic or relational approaches to psychotherapy, which might say something like, the ways people think, behave, and relate to others are adaptive and understandable. Adaptive meaning essentially kind of positive, or, you know, increasing the likelihood of survival, you know. And we might kind of elaborate on that a little bit to say to a patient or a client or a friend, you developed ways of coping that made perfect sense at the time, but are now causing you more harm than good. So it's a way of kind of saying to a person, well, you know, you went through experiences and you found a way to cope. So I not uncommonly see people who have functional neurological disorder. It used to be called kind of pseudo seizures, but people who have seizures as an adult, and almost universally they have been through early childhood trauma, and sometimes they will recall that the way that they got through that was by kind of dissociating, so sort of going to another place when it was happening, and sometimes that can then kind of develop into seizures when they're older. An example of how like that was the thing that got me through, but later in life that became kind of unhelpful actually, and now I don't want that to happen anymore. Put another way, when we think about kind of relations and relationships, so many different explanatory models or forms of therapy actually think, rather than think about the individual, they think about the space between individuals, like so the relationship. So they might say something like, you have developed ways of interacting with and relating with people that cause you problems. So this is less about kind of the way that you think, and it's more about kind of your relationships and how do you deal with relationships, how do you interact with people, and so on. And for some people, that might be a very kind of rich explanatory model or a useful one to help a person, move towards richer relationships or less suffering. In the middle of the 20th century, there was a development of a thing called social psychology, which was, just as we said a second ago, starting to think about society as a whole and how individuals function in a society, and what are the kind of contextual things that influence health. This is a picture of Marie Jahoda, who was one of the early, very prominent social psychologists on the left there. And my claim to fame is that the person she's talking to is Henry Kelly. And if some of you who are old enough will remember that he was a presenter on British television, an Irish presenter. And he was my next door neighbor when my parents bought their first house in Dublin. So that's the closest thing I'll come to a celebrity is Henry Kelly talking to Marie Jahoda, who's one of my heroes. So a social or a contextual explanatory model might say something like, unhealthy contexts give rise to ill health. And a context here can be anything kind of outside of you. So that can be your relationships, it can be your employment, it can be the kind of house that you live in, it can be discrimination. That these things have an effect on us, kind of independent of how we think about the world or how we think about ourselves. They have an effect on us, a pressure on us that can be beneficial and nourishing, or it can be harmful and toxic. If you think about the development of the kind of lifestyles we lead in a capitalist world, you might say something like this: climate degradation, pollution, meaningless work, financial precarity, and social isolation lead to increased rates of mental ill health. And that's, very hard to agree with. There's plenty of evidence that this is the case. Very hard to disagree with, I should say. Plenty of evidence that this is the case. And again, this is about like what happens to like groups of people when their context is really, really unhealthy. They don't have the things need to be healthy. Also related to the context of a changing world. So never before in history have things been changing as rapidly as they have been in the last 100 years. We've gone from the first airplane 100 years ago to landing on the moon 60 years ago to, having these computers in our hands all the time, smartphones. And an example of the effect that is having on people, you might say something like this: social media has many benefits, but chronic exposure, especially for young girls, is associated with worsening mental health. And I think there is enough evidence to say that this is the case now. And it's an example of how when things change rapidly, we can't change. I mean, we're still effectively the same humans that we were 100,000 years ago. But our context is changing very rapidly and is having unknown effects on us. Healthcare is also a context. So the way healthcare is delivered influences people's health. And with that knowledge, you might say something like, healing and growth is possible, indeed probable, in the context of a nourishing relationship. So over half the effectiveness of therapy is down to the quality of the therapist and the quality of the relationship. So actually, it doesn't matter what type of therapy you get, about over half of the beneficial effect of that is down to actually the quality of the relationship. And I think there's a very rich lesson there, which is that, and something that I have increasingly convinced of over the course of my career, is that in that nourishing relationship, and that doesn't have to be, a patient and a therapist, client and a therapist, it can be any kind of relationship. We know, for instance, in children who grow up in abusive homes, even if they have one adult outside of the home with whom they have a trusting and nourishing relationship, that can mitigate a lot of the effects of abuse. There's relationships that really lead to healing, both in the context of a professional relationship, but also just generally in life. And then there's positive psychology. Martin Seligman often thought of as the kind of father of positive psychology. And positive psychology takes a slightly different view to other types of explanatory models. A lot of the other kind of explanatory models are focused on, suffering and illness, right? So how does suffering and illness happen? But positive psychology asks the question, how do people live rich and meaningful lives? So positive psychology might say something like, absence of purpose and personal meaning give rise to unhappiness or even misery. And separately, moving towards things and relationships that are enjoyable or meaningful give rise to happiness or contentment. So you can think of suffering or unhappiness or mental ill health of various different kinds as like ways of thinking and ways of behaving, and things that cause worsening health or worsening experience. But you can also think of, instead of like moving away from pain and discomfort and suffering, you can also think of moving towards things that are rich and meaningful. There's a slightly different way of thinking about how to get better, but it is definitely a story that I hear a lot from patients who have made really meaningful recoveries in their life. It tends not to be because they've had some kind of treatment. It tends to be because they've met somebody who's who is loving and kind, or they found a career that they find really meaningful, or they found a hobby that they find really meaningful. And so I use quite a lot of positive psychology in my practice. It tends to be kind of dismissed a little bit because it's people think of it as the stuff of self-help books kind of, but there is definitely something rich there about developing and finding things in your life that are nourishing and make you happy. And it's a little bit related to this next model, which is the absence of necessary components for health. So there are some things we need to be healthy physically and emotionally, like exercise, connection with other people, sleep, or things that are really quite simple, in principle. So sedentary lifestyles, loneliness, insufficient sleep, etc., all give rise to an increased likelihood of suffering and poor health. So not everybody who lives alone and has a sedentary lifestyle and doesn't sleep enough gets sick physically or mentally, but some people do, and certainly the risk is increased. And so there's an idea that we're animals, right? We're social animals, and we have physiological and emotional needs. And if those things are missing, then that can cause problems. So it's another way of thinking about it. And then stress and the effects on the body. This is another important thing. Increasing evidence. Well, I mean, there's loads of evidence that stress itself causes illness and causes mental health problems. But there's increasing evidence that inflammation might be the kind of mediating factor. So people have probably come across this idea that stress leads to inflammation. So this statement is, long-term stress leads to inflammation and other effects on the body which cause symptoms like fatigue, anxiety, insomnia, and diseases, so heart disease and so on. So also certainly the case. And then also there's the effect of illness on the body. So this statement is, some medical illnesses present as so-called mental disorders, and thus these presentations will need doctors involved and require investigation. This is true. So most people, when they go to their GP for the first time with depression, the GP will run some investigations, because general kind of ill health or low thyroid hormone or some of the presentations can present very much like what we think of as depression. And so I don't want to create the impression anywhere in this talk that I'm like against doctors or medicine. I do think the model that we use is not fit for purpose, but it's likely to be the case that you will always need doctors somewhere in that kind of multi-professional kind of input into people's emotional and mental health as well as physical ill health. And then most people have a kind of an understanding that your personality, your temperament influences how you experience the world. So this statement, some people have a particular type of brain that makes them vulnerable to distress and the effects of adverse experience. And this is certainly true. So if you are more sensitive or more prone to anxiety and mood changes, you are more likely to suffer the consequences of difficult experience, which in turn can then go on to form one of those tightly coupled loops of depression and anxiety and so on. And it can be a really useful way of thinking about your experience, because you can't change the your brain, but you can learn ways of kind of navigating the fact that you have a more kind of a more intense and distressing emotional experience than other people. So you can't affect the waves, but you can learn how to sail. Is the way some people conceptualize that. And then finally, there are neuroscientific explanatory models, and they kind of propose mental disorders are caused by measurable abnormalities of brain function. And this is a much favored view by lots of different people. People love neuroscience. People love brain scans. They love the idea that there's a sort of a sort of scientific, brainy kind of way of understanding things. And I kind of understand that. There's something kind of sexy about it, I think. That's what people think. And newspaper article, you'll come across constantly in the media. We've found this part of the brain that when it lights up or it's overactive, that's what causes depression and so on. The problem is there have been no consistent findings really over the last 40 years. I've been practicing long enough to have lived through about 6 major hype cycles in psychiatry. When I was in medical school, they were teaching the pain is the sixth vital sign, which was basically advertising campaign by the opioid industry, which made it into medical schools. It was a big hype cycle. Nobody should ever be in pain. Give everybody opioids. Of course, that led to the opioid crisis. I lived through the Prozac hype cycle, genetics of psychiatric disorders hype cycle, and now we're in the neuroscience can answer everything hype cycle. And certainly in the future, we will have potentially a richer understanding of some types of mental illness, mental disorder, mental ill health from neuroscience, but we're, I believe, many decades away from that. And partly because all of this neuroscience research is based on those mental disorders, right, from the DSM, which don't accurately reflect reality. They're just they were developed as kind of heuristics. They were developed as kind of like shorthand for things that we think are happening, or describing things, but it has not been borne out that they represent discrete kind of identifiable things that you can then kind of do a brain scan and figure out what they are. Then the final, this is not an explanatory model, but I think it is important. Humility is important. And we may, for instance, there may be future discoveries of fairly straightforward causes, just like, pellagra or general paralysis of the insane. An example of this, and there are studies going on at this in the moment, is that there are individual case reports of people with, serious mental illness, which is a term used for bipolar and schizophrenia, who have effectively been cured by a ketogenic diet, right? So completely cutting out carbohydrates. Now, we don't know how common that is. It's certainly not going to be the case for everybody, but there are some very high-profile cases. People are familiar with Roblox. The CEO of Roblox, his son had very severe bipolar. They put him on a ketogenic diet, and effectively all his symptoms went away overnight. So there are going to be a handful of cases where there is going to be this kind of simple cause, but most people don't work that way. But we should be humble about kind of future discoveries, and many things I've said here today might be wrong, and you can throw that in my face and remind me of this presentation. It'll be on YouTube. So everyone has a model. So every patient who comes in, they have a model. They have an understanding of what's going on, right or wrong. And every professional you'll see will have a model, right or wrong. And it will tend to be the one they were trained in, right? So if you're a CBT therapist, you will think about the world in a CBT way. If you're a doctor, you'll think about diagnoses and usually kind of medication. But that doesn't mean that those are right. But they're also kind of, they're simple models. They're models that say everybody who suffers has a sort of a CBT type of problem. And that's not how the world works. That's not how people works. We remember H.L. Mencken, who said, for every complex problem, there's a solution that is simple, neat, and wrong. So how do we transcend this kind of simplistic thinking? Because we are complex. We are not, simple input-output devices. Chiara said at the beginning, she mentioned complexity science, and in the language of complexity science, we're complex dynamical systems, and we're embedded in other complex dynamical systems, and there are all these complicated interactions between all of them. But all of the explanatory models we've been through, they all have something to offer. They all may be the right thing for a particular person at a particular time. The best way of understanding, which offers the best solution, rather than this thinking of there's a cause and there's a solution. Cause, problem, solution. Actually, we look a little bit more like this. We have all these things that influence each other. Your loneliness makes you stay in the abusive relationship, which causes anxiety, which causes more fatigue and more insomnia, which etc. And we get stuck in this loop. And this is really what, when people say mental disorder, this is what they're talking about. They're talking about this kind of stuck system, of this vicious cycle system. And we look like this. We're embedded in societies and communities and families and so on that may tend us towards health, but may tend us towards illness. Gordon Paul in 1969 posed this question: what treatment by whom is most effective for this individual with that specific problem, under which set of circumstances, and how does it come about? And we've not got much closer to answering this question because we're stuck in a medical model, I believe. But there is light at the end of the tunnel, because different groups are starting to talk to each other. So the model of complexity science is actually that we say, okay, well, what can psychiatrists learn from psychologists, and what can they learn from sociologists, and what can they learn from humanistic psychotherapists, and what can they all learn from each other, in order to develop a pluralistic understanding for each person, so that we can, for an individual person, say, well, right now, actually, your context is really unhealthy. Your relationship, or where you live, or the job that you're in. But maybe in a week or a month from now, the focus will be actually on the way you think about yourself in the world, or your personal narrative. And then maybe another time it will be that you are, you're sedentary and you have really nothing kind of rich and meaningful in your world. And so it might be about kind of focusing on, say, building habits, or, focusing on your values, so that you can start to build, a life that feels rich and meaningful for you. And I think that is starting to happen. There is dialogue across disciplines. There's dialogue between neuroscientists who are trying to understand, say, consciousness, and psychologists who have a deep understanding of how people's kind of minds work moment to moment, and psychiatrists who are treating kind of physical illness, and or doctors who are treating physical illness, and psychiatrists who are treating mental disorder. And so I think there is definitely promise, though we are early in that road. There are lots of systemic things in the way. The way research works is that you tend to, you have a project and you do your PhD, and then you spend the rest of your career doing that. And quite often that tends to be down a track of kind of maybe a sort of simple cause, looking for a simple cause for complex problems. So I have hope that we are moving towards a more pluralistic way of understanding. So our patients come to us with these understandings of what's happening to them, and we work with them to build a more complex view of how they got to where they are and how they might get their way out. So as we said, there are various explanatory models. They all have something to offer. We've looked at how the medical model has become so dominant. We've understood that what we need is pluralism, so lots of different people with lots of different points of view. We need complexity. We need to understand all those different points of view in order to provide individualized care for a particular person. So I hope that has made sense and exposed you to maybe some ideas that you haven't come across before. I'm very happy to answer any questions that people might have, if anybody has any questions.
Thank you so much, Iain. I'll just stop the recording before we start the questions.